Welcome to 2024, Dinks. I am so pumped. We've had a lot of great things happen over the holidays. I hope all of your holidays were just amazing. I'm coming off a quick road trip to see Billy Joel, and we saw Spam a lot and got to spend some great days with family and our boys and the boys' girlfriends. And I know Chad and JB had a wonderful holiday as well. So anyway, welcome to Dentists in the Know and welcome to Humpday Happy Hour. This is your backstage pass for current trends, politics, and education in the dental world. It's live and it's usually over a cocktail. Tonight, a little hot toddy because it's getting a little cooler here in South Carolina. But anyway, I'm with two of my best friends in the world. They also happen to be dentists. They also happen to be educators. And they also happen to be business owners. And our job, the three of us, is to bring all of you in the know. Off to a racing start this 2024. I'm really excited, you guys. I don't know about you. Just so many cool things have happened for Dentists in the Know. And we have so many great things coming up. We have so much great content coming up. We have a phenomenal guest tonight. Dr. Mark Murphy is with us, who is the lead faculty at ProSomnus Technologies. And as you all know, I'm pretty involved with sleep and those kinds of things. And so ProSomnus is a company I happen to work very closely with. And Mark has become a good friend in the industry, but an incredible educator and also an incredible clinician. So can't wait to talk with him later. So ProSomnus, I got to give them a big shout out. And this is completely unsolicited. This is not a paid ad in any way. These guys had my back, man. We were trying to get a bunch of cases in before the end of the year. We knocked 12 of them out the Friday before New Year's. They promised us they'd be there. We got them off. They gave us a hard date in the middle of December. And man, they got everyone to us. We got 12 sleep cases in on the Friday before New Year's, just so we could get those people through their insurance. And, you know, it was ProSomnus have my back, man.
That's
They're good
huge.
people. So anyway, JB, we have a phenomenal guest tonight that everyone is waiting to hear from. So would you share some news? Is there any news since
there always is news? I will say it's a little quiet because, you know, whatever people have done up until now hasn't actually made it into the news yet, and there's no government activity yet. So all is a little quiet on that front. But unfortunately or fortunately, dentists are always kind of making their way into the news one way or another. So shall I proceed? Guys, there was a Michigan dentist. So this was, there are landmark cases that happen in our careers where you think, wow, that was a pretty big settlement, or that was a pretty big, financial cost that came to the malpractice for that doctor. So we do look at those as benchmarks to sort of set precedent. And obviously I always read them too for learning opportunities to, see. I know Jeff does this with his expert witness stuff. You know, we're certainly flawed and susceptible to human error, and recognize that that's a daily part of the risk that we take as clinicians. So when you read these cases, I do come at it with a level of humility to say, could this have been me? Could this have been a scenario in which I found myself in? Quite frankly, in reading this story, I do have to say, at least based on the information that has been published about the case, I'm like, oh, dang, like that snowballed really quickly, and unfortunate for the doctor. But there was a Michigan dentist who just settled a case for $400,000 for a patient who experienced brain dysfunction and other complications that came from an extraction. The extraction took place back in 2017, where they removed an upper maxillary tooth with an with a sinus exposure. And what came from the sinus exposure led to a significant, according to the documents, led to a significant sinus infection, which then ultimately led to the patient being hospitalized for 17 days, where she had to be intubated, was diagnosed with encephalopathy, respiratory disease, and acute kidney failure. She obviously came out of the hospital to live to see another day, but certainly had complications from treatment. And that particular general dentist has agreed to settle the case. For me, in reading that story, I was like, well, it's just a really unfortunate series of events that occurred. And maybe there were some underlying issues that were going on for the patient that, came to an ugly head after the extraction. But certainly could happen to any of us. So that was an interesting story. On the flip side, what made national news this week, and if you haven't heard it, you must be living under a rock, because even I heard a patient of mine tell a hygienist about the case today, of the Minnesota dentist who performed 20 fillings, 8 crowns, and 4 root canals in one single visit. She is now suing her dentist for pain and suffering, embarrassment, emotional distress, and disfigurement as a result of this long procedure. Here we have probably a situation in which the patient likely was sedated. They went to do a significant amount of dentistry in one setting. And then, the patient had challenges post treatment related to that amount of dentistry being done. This just came to light in the last few weeks. This was a case that occurred back in 2020. So we'll see how this sort of plays itself out in the news and whether or not this patient will be victorious in this lawsuit. But certainly, on our radar as well as we watch these cases unfold. Lastly, for this week, Pearl, who is a proud educational partner of Dentists in the Know, received a U.S. patent, official U.S. patent, for their computer vision software, which is the core of its artificial intelligence within its software. So they received the patent. That is patent number 11,776,677, in case you were keeping count. The computer vision based analysis of provider data. So we're seeing more and more of the evolution of AI and AI support within dentistry and the diagnostic tools as they're coming to light, and also watching these companies sort of grow and obtain the certain certifications, notoriety, and protection of their intellectual property as they are sort of pioneering the latest evolution in dental care for us practitioners. And with that, that's the news.
We have a terrific guest tonight who I've really been excited to get on. So I don't want to leave him waiting down there in the wings any longer. I met Dr. Mark Murphy. Oh gosh, it's got to be 7 or 8 years ago now. On the lecture circuit, he was doing a lot of things with consulting and educating, and I'd certainly known his name in the sleep ranks. And when I got to meet him, he was everything that I had heard about him. Just a super charismatic guy, great clinician, caring person, and just a hell of a guy to be around. So I'll read his official bio. In that nearly 40 years experience in the dental and dental laboratory professions, and recently in the manufacturing industry, Mark has a great perspective of the various functions and relationships between all of these entities. He's had a long-standing role with the Pankey Institute in Key Biscayne, and that's had a significant influence on his point of view. He's received various awards and honors within the dental profession. He sold his practice in 1998, and I believe he's a Michigan boy as well, but drifted towards a more global industry where really he belongs. When you listen to him and hear his very forward thinking. He really needed to be sharing his perspective on a larger scale. So he decided to serve with Dental Technologies, and he's been a consultant to several manufacturers, but he now serves as the clinical lead for ProSomnus Technologies. He is also on the faculty of UDM School of Dentistry. That's the University of Detroit Mercy, and he is also on faculty at the Pankey Institute. So without further ado, Dr. Mark Murphy, how are you, sir?
And it's more specifically, it's Murph Doggy Dog. If you want to use my Detroit rap name, let's keep it current. Let's keep it up right. And I've got a bunch of bones to pick because first off, I want the bourbon recommendations, and I want you to throw me a kegger party, for God's sakes.
You're in. You're in. There you go. Hey, I didn't pay for the keg. I didn't even have a beer. So
I bought the keg, Chad.
Thanks, Uncle Jeff. Austin
some,
appreciates it.
JB, you played some wickedly cool game with your family, and we played right, left, center. I don't know if you know anything about that game.
Oh, we played that too.
Okay, good. Well, it's a great game. It's like euchre for us in Michigan. When you get good and drunk, it's a great game to play because you can't screw it up. And you can be out of the game for 15 minutes and suddenly you've got, dollars again or whatever it is. That's good. And Jeff, I promise you the check's in the mail for the shout out that you gave to ProSomnus. I got my shout out right here. So that's good. And by the way, I apologize for stepping on that box. I'm a heavy man. I'm a big man. And when I step on a box, it's usually not going to end well. So, and I got to add to the malpractice conversation. There's been a large lawsuit filed here in Michigan just this weekend. I don't know if you knew this, but we're suing the referees for malpractice in the Detroit game, apparently.
For not reporting.
For reporting, yeah, there you go.
Just go for one, damn it. Just go for one.
What a cluster, I know. I got to be honest.
They were going to win in overtime. The Cowboys were sucking it towards the end.
I got to agree with you on that, so. There we go. And we've got Michigan, though. They've got a little bit of a game.
You've got a contention for national championship here. We can't be upset about that, right?
Yeah, except I would root for Michigan. There's no question about it. I would be rooting for Michigan. But I got to be honest. I chose not to go there. I was accepted to Michigan's dental school, but I went to University of Detroit Mercy because my wife was already in the program down there in the hygiene program. I married my high school sweetheart 45 years ago, and so there was no going anywhere else. If I went to a different school than her, there'd be shit to pay, that's for sure. So
yeah, well, I'm married to a Buckeye, so there is no other team. I
have to tell you. So when I've lectured probably 3 or 4 times now at the Ohio State meeting. When I'm down there lecturing, I say to myself, I say to them, I want to thank you very much for letting somebody from that state up there, that school up there, come down and lecture to y'all. That's very polite. Are a lot of you Ohio State graduates? And several people raise their hands. I go, oh, I'll talk slower then for you. And usually they don't say that, so it's a great way to break the ice. So
we say that about Clemson.
Right? What they call a beautiful woman on the Ohio State campus, a guest. Anyhow, but there's a million of those, right? They say the same thing about Michigan. So
that's
emails and a lot of stuff over there.
I think we all have those in each of our states.
Yeah.
Mm-hmm.
For us, it's
Mark,
the Aggies.
thank you so much for joining with us. And I know a lot of people want to find out more about. You remember when there was a time that it was pretty tough to fill a room with people who wanted to hear about sleep apnea, certainly about TMJ or bite problems. I mean, we were talking to.
That's all I've ever lectured about is TMD, occlusion.
Exactly. But it was a lot tougher to fill the rooms for a long time than it is now. And so all of this is finally getting its due, but it's something that, as you said, you've been doing for a long time. So maybe tell everyone out there about your journey in dentistry and kind of how you landed, maybe a little bit about your clinical history, but then how you landed in the world of sleep and then eventually with ProSomnus.
Yeah, so I guess about had to be around 19. Had to be 1991.
Okay.
1990 or 91. I'm teaching down at the Pankey Institute with Keith Thornton. And Keith Thornton, his last name starts with the letter T. and that's the first letter of the TAP appliance, one of the legendary appliances that's out there for treating obstructive sleep apnea. And Keith and I were teaching a TMD course down at Pankey, and he said in his lovely nasal voice that I had to start understanding sleep, and I had to start thinking about these people's sleep problems because bruxism and TMD and sleep was all kind of tied together. They were all part of a variety of syndromes that were linked together with sleep disturbances. And Keith's a brilliant guy, and so I believed him. And so, so probably, what is that, 33 years ago, I started making my first sleep appliances, some of the really rudimentary taps that looked like an upper impression tray with a handle sticking down and a lower flat anterior part. I couldn't close until you stuck your jaw far enough forward that the handle would slip down behind the lower member. So I treated sleep. So I was into sleep 30 some years ago. And I did that for a number of years, and I would treat my patients for snoring. I didn't involve physicians. We didn't do pre and post tests. We didn't titrate. And all those patients are going to listen to this podcast, and there's going to be a rage of malpractice suits in Michigan following me practicing medicine without a license, because I was clearly doing some of that. And I realized that I felt a little uncomfortable doing that. So I drifted away from it for a while. And I still did a lot of TMD, occlusal rehab, a lot of aesthetic stuff. And I was having a blast and teaching on a Pankey. And then as I moved away from practicing and more into lecturing, teaching, consulting, and all of that kind of stuff, I had a contract with a company called Microdental. I was still teaching at Pankey. I'd been full-time down at Pankey. I'd been on their board a couple times. So I had a pretty good pedigree, pretty good background. And I was at a contract with Microdental to do, I don't know, maybe 20 days a year of lecturing or teaching. They had maybe 15 or 17 labs across the country. So I'd go in and lecture and teach at their various labs. And they decided in 2013 to develop a sleep device. And so they hired a person to work on that, whose name I won't mention, but she turned out to be the wrong person. And she was trying to develop a Me Too device, which was just similar to some of the other devices that were out there. But when she started that project, I raised my hand and I said, I know I'm really just lecturing for you and everything like that for the company, but I know a lot about sleep. I've been doing sleep for, however many years that was at that time. So I was involved in the early development of their first product, which was called the Micro 2. And so in 2013, later in the year in 2013, I hired a couple of engineers away from 3M, a PhD and a project engineer, mechanical engineer, named Sung Kim. And they developed the very unique kind of 90-degree post, the iterative advancement model. They wanted to do something that would be a fully digital process. I had nothing to do with the creativity. I'd love to sit here and take some credit for that. Zero creative genes in my body. But I wore the prototypes. I gave them feedback, fun like that. And so that was in 2013. They got their FDA approval in 2014. I still had a contract with Microdental. In 2016, Microdental was getting ready to be sold to Modern Dental, who they're part of now. And at that time, the ownership structure for Microdental was selling Microdental, but they were not selling the ProSomnus piece of that, the oral appliance for sleep portion of their company, the medical device manufacturing division. So they spun that out as a separate company. And they asked me to come with them. And so I went with them in a full-time role initially. They still let me lecture a little bit on the side and everything. So I've been with them since they spun out in 2016. And I've had this educational role, and I've helped out in sales and marketing and all the various parts of the company. Had a little bit of a leadership role there as well. We went public last December in 2017. So we're actually traded on NASDAQ now, which is kind of interesting. Changes a lot of the rules and regulations of what you can and can't say about a company and everything, like when you can and can't buy stock and invest in the company and all that stuff. But it's been a great run, and ProSomnus has done a really nice job. So it's been really fun. Never saw that coming. Never saw me transitioning from full-time dentistry to full-time lecturing, teaching, consulting. I backfilled a guy named Imtiaz Manji when he went to Spear, when Mercer Advisors sold to an investment capital company. Part of the deal was he was leaving. And so with his departure, they needed somebody to backfill for him. So I spent, I think, about 4 years running their consulting program at Mercer Advisors. And then when that ended, I rolled back to the laboratory side of the industry where I had some expertise and some credibility. So it's really been fun, but I never saw it coming. I'd be a lot smarter person and a lot more impressive if I had said I laid out this great plan and executed the plan. But instead, the door would open, I'd walk through it, I wouldn't screw up too bad, and they'd keep me around. So I got lucky several times. Didn't shit the bed, as they say.
It's a great story, Mark. And tell us what makes ProSomnus so different than a lot of the other companies, because everybody tried to jump in on this. They say, oh, sleep's a hot thing now, let's jump in on this. What makes ProSomnus so different than a lot of the other sleep technology companies out there?
Jeff, that's a good question. So I think that when you think about oral appliance therapy and you think about its roots, it helps explain what and why and how ProSomnus has evolved as a very different kind of entity. Oral appliances came from people like Keith Thornton, who was a tinkerer. He invented something that was an anterior deprogrammer that Jim Boyd has made famous with the NTI device, for example. So he's invented a lot of tinkering kind of things. He's worked on some articulator systems, stuff like that. So a dentist thinking like a dentist, developing stuff using dental materials, dental supplies, jack screws, Herbst arms, whatever they can think of, straps, to help hold the jaw forward, knowing that if I held the jaw forward, I would open the airway in the back. It's just mechanics, right? Doesn't work for everybody, but works for a lot of people that have sleep apnea. If I hold their jaw forward, I open their airway, it doesn't collapse as much, just mechanics. And so the idea of a dentist developing dental stuff, that's going to be done in the dental lab. And so all of the first oral appliances had some component that was a dental piece, a dental part, a dental material, and designed by a dentist. And today there's probably somewhere between 180 and 190 different FDA approved appliances for treating obstructive sleep apnea. And all of them fit into this mold, except for one group. All of them fit into this mold of, hey, here's what we were able to come up with, being dentists and thinking of dental materials, everything like that. So when ProSomnus decided to develop that, they hired somebody who had experience in sleep, and I told you she didn't work out because she was trying to develop another dental-like device. And when they hired the two engineers from 3M, I love this story. We met with them several times, and we talked to them, and they asked us design input questions. And I said, what do you mean by design input? Well, what would you like the device to be able to do? How would you like it to be able to act? And they asked us a lot of questions, not starting with a framework about dental materials, dental supplies, and like that. So when they showed me the first prototype, I looked at it and I said, holy crap, what is this? There's these 90-degree posts. And they said, that's what you asked for. And I said, we never talked to you about 90-degree posts. And they said, yes, you did. I said, what did I say? And they said, well, you said that once you got the mandible into that treatment position, you'd want to be able to stabilize it there. And if we make that post at a 70-degree angle, like all the other posts have been made, or we put a 70-degree strap there, or we put a 70-degree Herbst arm, because that's the normal motion of the mandible, then if the patient's mouth drops open, it rotates open. And as it does, the mandible retrudes and falls backwards. And you told me, he said, you want to stabilize that in the treatment position. And I went, holy shit, I never thought of that. But that's because this was an engineer who wasn't thinking like a dentist and said, here's the design input you gave me, here's the output I gave you in a product. And then I looked at it and I said, wait a minute, how will you adjust this? There's no jack screw, there's no Herbst arm, there's no strap, there's no buttons, what the hell? And then he reaches behind his back and shows me a couple more arches. And he says, you'll trade out the arches, the posts will stay in the same place, and the relationship between the maxilla and the mandible will be altered in millimeter or half millimeter increments, whatever you need. And I said, that'll never work, son. He said, why not? I said, it's going to be so expensive. You can't make 4 or 5 devices for a patient. He said, Mark, it's plastic. And the machine is going to mill it. When a person designs it, that's where all the expense is. And then they're going to mill it out of a chunk of plastic. And it's going to be stronger and smaller. And it's going to have these 90-degree posts. And I'm just slapping my head, over and over again. Could have had a V8, I guess. And I'm thinking to myself, you got to be like 60 to be able to remember those old V8 commercials. Guys eating something, slaps stuff there. I could have had a V8.
Yep.
And
you don't have to be 60.
Thank you. Well, you have to have somebody that's 60 in your family. There you go. So that whole design thing. So then the company designs this incredible device. And then what do? They go out and they back it up with all kinds of science. So if you look across the other designs, there's no other precision oral appliance like ours. Now, there will be in 3 to 5 years. Every other manufacturer is going to start making them like ours. They're going to make them better. All the other devices are going to go away because we get far better efficacy. We get far better science. Physicians are falling in love with it. We're going to get a severe indication clearance. We're putting oxygen sensors in it, so it'll read the oxygen sensor technology right while they're sleeping. Incredible stuff that we could do, again, because of this digital, artificial intelligent robotic manufacturing process. But the science we decided physicians weren't listening to dentists about oral appliance therapy and whether or not it worked. And you know that, Jeff, because you've been doing this long enough too. They just laugh in our face because the science we have is Mark Murphy writing in Dental Economics, or Mark Murphy writing in DSP, Dental Sleep Practice Magazine. These are rags that we toss around. These aren't real scientific journals. Well, we've got dozens of articles now published in medical journals, some done by physicians or physician dentist teams in peer-reviewed independent studies. No one else has the kind of data we do. Now, when they look in their own journals, Journal of Clinical Sleep Medicine, Chest, Army Medicine, and they see articles about oral appliances and their efficacy and their adherence, they take notice. So this company has been on a path since 2016. We didn't exist as a company prior to that, and now we're the largest manufacturer in North America. Yep. So it's been a really fun journey to be part of something that's just trying to do it well, trying to do it better, no shortcuts, trying to get cases out, turn them around faster, because they're milled by machines, so we can do things other people can't do. If another company that makes pink devices makes them in the Philippines, there's going to be more shipping going there, more shipping coming back. So, we make them in California, which is stupid. It's not a great place to make it. It's so expensive to make them there. But we could probably cut the price in half if we made them in, some small town somewhere, but near an airport. But you get the idea. But that's primarily what makes us different. I would tell you our people make us different, and our dedication. I could tell you all kinds of great stories about good things we've done and people and our green activity and our science. But it's really, we had a mission to make a better device, and we designed it from the ground up. And we act like medical device manufacturers. These are class 2 medical devices. They're not bite splints. Those are class 1 medical devices. And there's a whole different set of rules and regulations with the FDA that, quite honestly, other manufacturers are probably skirting some of the rules and laws on a regular basis in how and when they make them and modifications they make to them, et cetera. We just can't do that. These are medical devices. We're not ever really treating the patient. The physician's treating the patient. We're filling a prescription for a piece of durable medical equipment, just like a medical supply store is filling a prescription for a knee brace. Our job is to make sure the patient can wear the knee brace, fit the knee brace, adjust the knee brace, but we're not treating that person's orthopedic problem, ever. That is so weird. We're just this prescription filler in this medical system. It's a medical problem with a medical solution, with a medical device solution that just happens to be fitted by a dentist. So that's, our role's cool. Talking about all those lawsuits, when somebody dies or something goes amiss, everybody gets sued. But in this case, we're just filling a prescription somebody else wrote. We didn't decide that patient's having an oral appliance. The physician did. We fitted it. Now, if we screwed up fitting it, we malfeased the patient, maltreated the patient. Shame on us. But man, it's pretty clear and devoid of a lot of those potential negative consequences you all were talking about. I don't think you're going to see a lot of sleep in the news. That's for sure. I think what you will see in the news someday is a dentist not screening his patients for sleep apnea, and somebody dies on their watch.
100%.
That we're going to.
So I absolutely love what you just said. I think that's one of the best analogies I've ever heard. We're kind of a pharmacist, if you will, for a prescription from a doctor regarding a dental device. But if that's the case, how would you suggest? I mean, there's so much talk about sleep dentistry, about obstructive sleep apnea. The ADA has kind of outlined how we should be screening patients and be, understanding of the problems that they're going through. Where would you suggest that a dentist gets started in this journey, and who would you suggest that they befriend in the community so that they can build a network of referrals and build a, kind of a sound base for delivering these prescriptions?
Chad, that's about 4 questions in one. So
It was specifically, yes.
That's great. I'm going to break them out. The first thing is, the ADA didn't outline for us. They wrote a resolution in 2017.
Sure, they suggested, I guess, is maybe.
No, it's a resolution. It was passed by the ADA as a resolution that we should be screening our patients for obstructive sleep apnea. That's why.
Can I interrupt for a second?
Yeah. Yeah.
You know why they felt pressure to do that? Because we wrote the resolution in 2016 at the Academy of General Dentistry.
Excellent. Excellent. The American College of Prosthodontists also wrote a white paper that said if you're going to make a bite splint for a patient, you should first evaluate them for sleep apnea.
Absolutely.
If you make a bite splint for them and you open their VOD, they automatically rotate, and that closes the airway, and that could make their sleep apnea worse. So I literally making bite splints in centric relation and mounting everything on an articulator my whole career I was killing people and not knowing it. So we'll start with, we sort of have a responsibility to screen. Now, don't hear me as you have a responsibility to treat. I have a responsibility to screen my patients for whether or not they should have their third molars removed, whether or not they have periodontal issues, whether or not they have orthodontic issues that I could refer them out for, whether they need a root canal. I don't have to do any of those specialty procedures, but I have a responsibility to screen for those things. And so this getting added to the list, for my money, probably doesn't make sense because it's a medical condition. Just like, are we supposed to screen for hypertension or smoking cessation, weight loss? I mean, where does it stop? Put everything on us because we see the patients regularly? That's not fair at all. But there is this resolution, so it's going to come back to haunt us someday. Well, how do we get started? Well, first off, I'd say everybody should just be screening. You should add a very simple questionnaire called an Epworth Sleepiness Scale to your health history. You should be thinking about what's called a stop bang. Does somebody snore? Are they tired? Has there been an observed stop breathing? Do they have hypertension or some other comorbidity? Do they have a heavy BMI, 30 or more? Are they over 50? Do they have a neck size that's larger? And are they male? And if they have 3 of those, they're at risk for sleep apnea. If they have 4 of those, they're at high risk. So be thinking about this Epworth Sleepiness Scale. Are you tired? That's a good conversation starter. Have this stop bang. And in an average practice that has a couple thousand patients, they have about 500 patients that have sleep apnea, 400 of which that have never been diagnosed or treated. So right under your nose is a gold mine, if you want to think of it that way, of treatment opportunities if you choose to treat them, but screening responsibilities even if you don't. And so there's a large number of patients right under your nose that you could screen for, treat some of them, have a nice day. But that's not going to get you, like you mentioned, with the physician referrals and a referral relationship down the road. So during the course of seeing your own patients, you're going to want to establish relationships while you're doing that with physicians outside your practice by maybe sending them some of these patients for screening, testing, working with some of them. You might use some in-house testing as well, some online testing capabilities with telemedicine. There's some great opportunities there to streamline procedures, but some of those patients, you should work with your local physician so you develop relationships with them. You should use devices that get good results. You should work well with the physicians, communicate, follow their rules and guidelines. You should not be anti-CPAP. CPAP's a great treatment for patients who can tolerate it. For patients who can't tolerate it, oral appliances are a far better therapy. United Healthcare, for example, just came out with the other day, it was just published, new guidelines for 2024 stating that no patient is going to get Inspire surgery unless they failed oral appliance therapy. Previously, they had to fail CPAP. Now they have to fail CPAP and oral appliance therapy. And that makes sense because why would you let somebody have a $40,000, $50,000 surgical procedure done if they haven't done something that's just going to be a couple, $3,000, $4,000? That's much less expensive. And we have better efficacy than Inspire. Inspire only
does the same exact thing and in more areas.
Yeah. Our adherence is even better. The adherence for CPAP, on Inspire, they only turn it on 71% of the time. And oral appliances are worn, 80 to 90% of the time, depending on whether they're, just custom or whether they're precision devices. So if somebody wants to get started in sleep, they should go get a little bit of education about sleep. They don't have to get a lot of education to screen, but they've got to get some education if they want to treat. And as much as you could take classes with Jeff Horowitz Incorporated, you could take courses with Awaken to Sleep, DS3, Nearman. There's lots of places. You'll probably want to add to your list the American Academy of Dental Sleep Medicine. And the reason you'll want to add that is because whether we like what they do or don't like what they do, they are de facto the voice for dental sleep medicine. They have about probably close to 4,000 members now. They have over 1,000 qualified dentists who've been tested and vetted, or diplomates like Jeff and I, who've achieved a certain level of education and testing, and we prove that we know what we're doing. Sort of like a fellow in the American Academy of Cosmetic Dentistry or something like that. We've jumped through some hoops. And so they've become the voice for that. So I would not want to, if I was a physician, I would be hesitant to work with somebody that didn't have some credentialing behind them. And there's no specialty for this really yet. There isn't like a graduate program for this. There are some mini residencies you can take. But suffice it to say, you'd want to become at least a qualified dentist with the AADSM, take some of their coursework. They have a thing called the Mastery Program. If you decide to go on for diplomate status, it's just more involved, more weekends. You spend a bunch of money, a bunch of time. It's good education. You want to find somebody in your community, and dentists are funny about competitiveness. There's no shortage of patients or anything, so we should be able to share great ideas with people across the street or down the hall from us in the same building. But should be somebody within driving distance of you who's already doing sleep, that you could, go shadow them, find out what they do, how they do it. You'll need a billing company. You'll need a documentation software. There's parts and pieces, but the rewards of watching patients get back in bed together with each other. Boy, that sounded creepy, didn't it?
Yeah, that kind of did, but we're just going to let that roll off the tongue. You're good.
Can you let that out? The possibility of putting couples back together. I don't know. There's just no way around that.
I've got a funny story at the end after we're done about, yeah.
All right. I have a question as someone who has taken a Dr. Jeff Horowitz course multiple times, who also has sat through many AADSM lectures and did a lot of the designate stuff. Haven't done the diplomat stuff yet. So I'm floating in this middle space where I want to treat sleep. I screen for it. I have hard conversations with patients, particularly pediatric and parents, about my concerns about sleep issues. I don't see myself as a durable medical equipment specialist. I see myself as a clinician. And so I'm floating this very weird line between someone who is trained as a clinician, who understands how things work, how people operate, the biology of what's happening. I also see some of the, frankly, I'll be very honest, the negligence on the sleep physician side of like not having those relationships with patients and just doing the sleep test and giving them the diagnosis and then sort of sending them off to the DMEs to figure out how to treat. And so you find yourself in this weird operating space where how do you take care of the patient? You see them twice a year, 3 times a year, whatever. You're building those relationships. You're responsible for the appliance. You know more than what someone who's selling a CPAP machine knows. And so this is just my own trials and tribulations as this kind of quasi-sleep clinician out there trying to do the best thing for their patients and yet finding themselves in this weird legal, regulatory operation space where I know it can be better, but I don't know how to do it.
Mm-hmm. So I feel that pain. I want to say every day, but that'd be a lie because I only do this a half day a week, seeing patients because I have a full-time role with ProSomnus. So I feel your pain a half day a week. When I'm seeing patients, there's many times where I want to make thoughtful treatment recommendations that are outside the scope of what I'm legally allowed to do. And I'll give you an example. I could say to a patient that I think they should try positional therapy, or I think they should use nasal cones or mutes. Very simple suggestions, over-the-counter suggestions. But when they're coming from a clinician, I'm technically then stepping into the treatment room for that patient. So my careful wording would be, hey, Jennifer, a lot of my patients have had success by sleeping more on their side than on their back with the oral appliance, because on your back, your jaw falls backwards, your tongue falls backwards. And so ask your physician about that. They're not going to ask their physician. They're just going to go out and sleep with a backpack or a fanny pack on. So these kind of quasi-recommended treatment options, you find yourself kind of dipping your toe into the treatment side and making suggestions that the physician might not have taken the time to do. So that is a quandary, but you do have to get comfortable with the idea that you're not treating the patient and you're not responsible for the patient. And I'll tell you why that's very important. On your best week, you're going to be successful, including mild, moderate, and severe patients, successful treating 80% of those patients. 90% of the milds and moderates, maybe 70% of the severes. So net, probably about 80% of all those patients. So that means 2 out of 10 patients, I got to look them in the eye and say, Chad, I'm really sorry. This treatment is not going to work for you, is it? We're not getting your numbers down to where they need to be. You're going to have to go back on CPAP. I'm going to have you go see your physician and talk to them about other options, what you can do. And you're like, well, I don't want to wear a CPAP. I go, I understand that. I'm not treating you. The beauty of that is I can let go of a failure, which we never do in dentistry. In dentistry, we can always fix something. You can always fix the filling. There's a cavity. You can always put a filling in it. It's bigger. It needs a crown. It's gotten into the nerve of the tooth. We do a root canal. We lost the tooth now. We can do an implant. There's never I can't fix that option. There's not enough bone. We'll graft it. You never say you can't. And the moment something goes wrong, you always feel like you're a failure and you feel like you're giving them their money back on something. Otherwise, they're going to sue you like your news report had, right? So here in medicine, that's not how it works in medicine. In medicine, you go, we set your broken arm with a cast. It's not healing well enough. We're going to go after and surgically put a rod in that. Well, why didn't you make that decision the first time? Because we tried to do something that was less invasive. It didn't work out. We tried this cancer treatment. It didn't work. The chemo didn't. Now we're going to have to do radiation. It's not going to work. You don't get your money back. So there's this weirdness to this emotion that's also hard to get over. So yeah, you're a DME provider when you put on that medical hat. Your role in medicine is a DME provider, you are a clinician, but you're not the primary caregiver. You're not the responsible. You're a renderer of a fitting for a DME. And that is weird. And then you're not going to be successful 100% of the time. That is weird. And then the rules and regulations for billing are different. The rules for documentation and soap notes are different. So it's a whole different world. But when you see patients getting back into bed together, you see people able to lose weight, able to go off their medications, telling you they feel so much better, they have so much more energy, it's worth living again. That's incredibly rewarding. And oh, by the way, it pays great. It pays about 4 to 6 times more than the average productive per hour capability of a dental practice. So on the one side, yes, all of your issues are legitimate. And a lot of dentists will say, well, I tried doing sleep, I couldn't get paid. That's because they were probably too cheap to hire a billing company or get the right software, and they weren't paying the price, so to speak, to get what they needed. And so they had trouble getting paid. But, you look at somebody like Jeff and you go, wait a minute, he's figured it out. And figure out how many devices he does per year and figure out what he bills out for insurance per year, what he collects per year. And there are dentists doing more than the average dental practice, working 1.5 days a week. Now, that's not the reason to do something like this, but it can be figured out. Is it right for everybody? Oh, hell no. I couldn't do endo to save my life. I didn't want to do extractions. God, I had to do them at this free clinic I worked at. Hated it. I didn't want to do ortho. I didn't want to see. I loved kids when I was first practicing, but once I started to develop some gray hair, you put a kid in my chair, I'd fire you, So we change and we evolve. And so my scope of practice said, I don't like to do these things. Well, somebody could say, I don't like to do sleep because of this, because it is a different mindset. But you might spend an hour and a half with the patient and collect $2,000 or $3,000, $4,000. It's crazy. Math is crazy on that. And so even somebody saying, well, I'm going to just treat my own patients in my practice, and they add 1 or 2 devices a week, 1 device a week, phenomenal. And if you had 400 patients that had sleep apnea undiagnosed in a practice, and you only treated half of them, that'd be 200, and you treated 1 a week, it'd take you 4 years. It'd take you 4 years. And at 1 a week, if it was $3,000, say it was $2,000 a week, that's $100,000 a year in production added with a great net on it. So when you start to balance it out, you decide, I might want to do that. Maybe it is worth the hassle. Maybe it's not, and that's okay. I don't care how much you paid me. I was not going to do endo. I was not going to do extractions. If a loose baby tooth could come out with topical, I'm your guy. If it's more than that, you're out of my office. But make bite splints all day long, do equilibrations, mount things on articulators, happy to do that all day long. So yeah, I get it. It's not for everybody, and it does require a very different mindset. And how do you come in and see one patient and you're doing a hygiene check, then you come over here and you're doing a composite, and then you come over here and you're seating a crown, And then you come in here and you're treating a sleep patient. You got to shift gears all of a sudden to the medical model. And that's different talk track. So usually the successful people segregate that to 1 half day a week or a day a week or something like that. It's hard to mix that in with the rest of your schedule. It's good to turn on. I'm coming in on Wednesdays. On Wednesdays, I'm a DME provider. Mondays, Tuesdays, and Thursdays, I'm a dentist. So there's different ways of dealing with that. But you're right. It's not for everybody. It's not easy. I totally agree with that.
Mark,
totally
you said a couple of really interesting things, and we're running kind of short on time now. I'd love to have you back sometime and really take a deeper dive into some of these topics. But you said a couple of things that I think really resonated. One is you do have to make some investment. If you decide this is what you want to do, you need to hire a dedicated assistant that is only overseeing this part of the practice and the relationships with the physicians and the follow-up paperwork and the billing. You can't just expect this to fit, neatly inside of a dental practice, because it is completely a completely different practice model. But with that said, if you're willing to make the investment to hire that right person that has some experience in doing that, and get the right billing company and get the right software to make it possible, really it can be run as just an extra little piece of your practice that makes money, or as a separate entity, as I did in my practice. So there's so many options out there. But I think what definitely needs to be heard is that, even though we are basically filling a prescription and acting as a DME, there are several things that, because we're dentists, that are still going to end up back on our laps, which are things like, issues with the jaw joint, which I'll be the first to say, appliances don't cause TMJ problems. In fact, most of the time they make them better. Exactly. But a lot of people who get into appliance therapy really don't know the anatomy and physiology of the temporomandibular joint. And so they become freaked out when some of these issues come up, where people complain of some muscle soreness, or, they take the appliance out and now their jaw joint is hurting. So there's so many areas that we need to be aware of. But this is such a great, fun, and fulfilling piece of what we can do as dentists, that I really think everybody should be screening, as the ADA and AGD say we should, not just because they say we should, but because of the good that we can do for so many people, and how good it makes us feel while we're doing it.
I totally agree. Yeah, I'm happy to come back sometime.
And you got to get over your shyness first.
I am very
shy. Yeah, please.
Well, Chad, do you want to close us out first? Mark, thank you again for being with us. What a pleasure. And again, completely unsolicited. ProSomnus is not paying for this in any way. I will just say they've been a great partner to me personally in my practice, and I would advise anybody to check them out if you're going to be offering these kinds of services in your practice.
Yeah, if somebody has any questions, they're welcome to email me at mmurphy, so it's mmurphy at prosomnus.com. Happy to answer any questions or get on a call with somebody.
Thanks a lot, Mark. Chad, you want to close us out?
Yeah, Dr. Murphy, I just want to thank you for being here tonight.
Close us out? Would that be good?
What's that?
Sing the Michigan fight song to close us out? Is that what you're thinking?
I don't know that I know it. Yeah, we could. But no, thank you so much for being here. It was a wonderful night. I think I personally learned a lot. I know that Jeff probably didn't. JB, I'm thinking that you probably did as well. But
always.
One of the most refreshing things that I've heard in a while is that we're responsible for filling a prescription that's prescribed by a medical doctor. And if we're doing it any other way, then we're kind of doing it wrong. So, I think it's a team approach. There's other viable alternatives, but if we get to this point, this is a wonderful alternative to treat your patients and make their lives better.
Sure.
I certainly have a lot to learn. I learned so much from Jeff, and I learned a lot from you tonight as well. So if anybody is interested in incorporating this into your practice, please seek Dr. Murphy or Dr. Horowitz and find where you can get started. And I think it's just a wonderful avenue for us to improve our capabilities as clinicians, our lives of our patients, or the lives of our patients, and boost our revenue in our practice. So thank you very much for being with us tonight. And until next week, we will just go have fun and see you on next Wednesday.
Sounds great.
So poetic.
Appreciate
Good
you.
night, everyone.
Good night.
Good night. Sweet dreams.
Go Big Blue.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.